Hi, everybody. Welcome to our Eye on the Expert webinar series. Thank you guys for joining us and for registering ahead of time so that you could be part of our webinar. Today, we're going to be joined by 3 different guests, and we had a slight change in program this week, and we are delighted to have Dr. Chmielowski, who is a medical oncologist from UCLA, and his kind of co-conspirator, so to speak, in the Hepzato world, Dr. Padia, who is an interventional radiologist. And we are also joined from all the way on the other side of the country at the East Coast from Boston, Mass General Hospital, and that is Dr. Cam Montazeri. So I'm going to bring them on. I'm going to bring my screen down in just a second. But as I bring them into the webinar, I just wanted to make sure to thank all of you guys here who are listening, and just also send a massive, massive thanks out to our sponsors. Our webinar sponsors are who make this possible for us to produce, to plan ahead of time, to have the registration platform, and then to just kind of get the word out to all of you. So those of you guys who are listening, would love to hear in the chat where you're from. And if you're here as a patient or as a caregiver, as a practitioner, we would absolutely love to hear where you're at and just have you guys interact in the chat. Dr. Padia is going to present a little bit of the data about the Chopin study. Or the Chopin study. Sorry, we're going to all learn how to pronounce this. We're going to all learn how to pronounce this study, but it came out in ESMO in 2025. And our goal here is to kind of just share those study insights, but also to help you guys as patients, as caregivers, learn kind of some different ways that doctors in the uveal melanoma treatment space are personalizing metastatic treatment using the theories, using the science, using the data that we have to support following the Chopin protocol. These doctors are people who have been utilizing Hepzato for a really, really long time. I guess it's been out for we're coming up on 3 years, I think, as far as FDA approval. And each of them has kind of unique processes in how they do this and reasons why they do it. And I'm super excited to have all of them on to answer questions for the audience, those of you guys listening, but also to answer the questions that I have in planned. Anyway, so thank you guys again for being here, and I think let's go ahead and get started with Dr. Padia's presentation, if that's okay.
Hi, good morning, Danae. Thanks again for the invitation. I'm just going to share my screen here. Mm-hmm. All right. Danae, can you see it okay?
I can, yes. It looks
okay. Great. So good morning, everyone. So what I'm going to do, my name is Sid Padia. I'm an interventional radiologist at the University of California, Los Angeles. I work hand in hand with Bartosz Chmielowski, who's here as well, who's our medical oncologist who sees most of our patients. And I'm going to talk about a new clinical trial that just resulted in late 2025 called Chopin. So I'll go over the overview, and then I'm going to kind of digress in the beginning to try to give you like a 2-minute overview of liver-directed therapies, which is kind of what I've focused my career on. So this is kind of the title. It's obviously a long title for the Chopin study. This was a single center study. It was done in the Netherlands, and it was randomized. Now, when we talk about liver-directed therapy, it's you can see it's kind of like this alphabet soup. A lot of this depends on not just how patients or people present with their tumors, but even institutional or operator preference. So, for example, at UCLA, we tend to have a little bit more bias towards something called Y90 radioembolization, as well as the Hepzato procedure, also known as percutaneous hepatic perfusion, PHP. But other institutions may do things a little bit differently, so it's just kind of different flavors. So in brief, many patients who have liver metastases from uveal melanoma will get an arterial therapy. And what that means is we put a catheter, typically at the top of the thigh, through a tiny little incision, and we use X-ray guidance to get that catheter into the artery up to the tumors, and we deliver something. And that whatever that something is there to kill the tumor, kill the metastases. So sometimes we can do something called TACE, which is transarterial chemoembolization. The chemo that is used is called BCNU. You can also infuse a immunomodulating agent called GM-CSF. And what we typically do at UCLA is our preference, institutional preference and operator preference, is to do something called a Y90 radioembolization, where we infuse radioactive beads into the tumor via the artery to kill them as well. And all of these have, I would say, advantages and disadvantages for each and every patient. Now let's go back to the Chopin trial. So what was this trial? This trial was patients with, so every patient, every trial has what's called an inclusion and exclusion criteria. So it's important that, all of us, in the medical world, we always look at the IE or the inclusion exclusion criteria. So when we're trying to apply this trial to our patients, we want to make sure that they're kind of the same match. So I think I didn't list all the inclusion criteria here, but the main thing is that these people had to have had metastases to their liver that's at least predominantly in the liver. Additionally, you could see this less than 50% by volume. So in other words, if your liver is completely taken over by tumors everywhere, you're not really a candidate for this trial. It was really meant for people with lower than 50% of the liver is taken up by tumor. And you could have gotten prior treatment such as chemoembolization, that's TACE, or Y90 radioembolization, also abbreviated as SIRT or SIRT. So they looked at standard endpoints, and this is again a little bit alphabet soup here, but what we often do is look at what's called the primary endpoint, which was basically how you were doing at 1 year, at 12 months. The enrollment was designed for 76 patients. So what they did was they did what's called a randomization. So you sign the consent, you enroll, and for those of you who have enrolled in clinical trials, you know how that works. But if you haven't, then basically a computer randomly allocates you to, let's say in this case, group 1 or group 2. And in group 1, you got the Hepzato procedure. That's abbreviated PHP. That stands for percutaneous hepatic perfusion. And I'll show you a couple of pictures of how that works for those of you who have not received it. And so that you can see that top row, they got randomized to PHP at week 1, and then you go all the way to week 7, and you get another round, which is typically what we do. Alternatively, you could have gotten PHP plus immunotherapy. Now, in this case, the immunotherapy was kind of, I would say, the standard of care in most patients, especially when the trial started, and that's ipilimumab and nivolumab. All the trade names in the United States are Opdivo and Yervoy. Bartos, did I get that right? Is that okay? I'm not an oncologist, so I'm trying to, learn. And so you could see the schema here. So they got like a dose of Ipi-Nivo. That's through an IV in your arm. And then you get the PHP the next week, and then you get 2 more rounds of Ipi-Nivo, and then you get another PHP, and then you get another round of Ipi-Nivo. Okay, so the goal was to compare people getting the Hepzato procedure or PHP versus people who get combination. In other words, PHP plus immunotherapy, and see which one does better. Okay, I'm going to step back and just give a 2-minute overview of what is Hepzato, or also known as PHP. This is kind of a schematic diagram. The procedures are done in the hospital. They're done under anesthesia, so you're completely asleep. The procedure itself, including anesthesia time, takes about 3.5 hours. We at UCLA did a patient yesterday. My procedure time was 2 hours, 10 minutes. Total anesthesia time plus procedure time was about 3 hours, 20 minutes. So that's kind of your time frame that you're looking at. And then afterwards, we keep people in the hospital for 1 night and then just discharge them in the morning. So all of this are done through pinholes. And by pinholes, I mean the incisions are typically like 1/8 of an inch, maybe a little bit smaller than 1/8 of an inch. There are 3 of them primarily. One is in the left upper thigh, one is in the right upper thigh, which you can kind of see on the schematic here, and one is at the base of your collarbone on the right side. The goal here is on the left side, where you can see that syringe. That's that catheter that goes into your artery, and then it goes into the artery going into your liver, and that's where we're infusing the chemotherapy, and the chemotherapy is called melphalan. Then on the bottom right leg, or excuse me, on the right leg, you have another catheter that's in the vein. So that vein, that catheter is, again, by catheter, I mean like kind of hollow bore plastic tube. It has 2 balloons, which you can see right in the middle of this PowerPoint image. And what that does is it isolates the veins in the liver and it's on a withdrawal. So it sucks the blood from the veins, it sends it through this box and through these filters, which you can see on the left side of the screen. And what those do is it extracts out the drug. It returns your blood back into another catheter in your vein at the base of your collarbone. So basically, it's like a 360, circuit where it's filtering out the chemo. So the entire purpose of this is to deliver high dose of chemotherapy into the liver, and you take out the extract so it does not spread throughout your body. And as a result, about 1 to 2% of the drug that we give ends up what's called systemically or in the rest of your body, and the rest of it gets filtered out. So it tends to be very safe. This is kind of another cartoon schematic of how this procedure works. There's a company that makes this entire device and the drug. And then again, we isolate the liver. We saturate the liver with the chemotherapy, and then we filter out the chemotherapy with this circuit. So I'll give one example. This is a patient not on that trial, but kind of similar, progressing on immunotherapy. You can see this is an MRI, kind of 3 images from his same MRI, just high, medium, and like kind of the low part of the liver. That big gray structure with the white lines is the liver. And everything in the yellow, those are tumors. Those are uveal melanoma metastases in his liver. And what we do is this is his chest x-ray on the left. And you can see this catheter coming in from the patient's right collarbone and so on. And then the catheter is coming in on the right. The right image is of his abdomen. The catheter is going north from the legs. This is kind of a picture of how it looks in our room. You can see it's kind of a zoo. There's I would say 10 to 12 people doing this. So it's not a one-man show. This is a big team effort. We have a lot of physicians, technologists, nurses working hand in hand. So I think the hardest thing about setting this up, not only at UCLA, but every program was getting everybody on board and to work together and to act as a team. So I'll try to speed through this, but this is a picture of what's called an angiogram. You can see this catheter going north from the bottom of the image to the middle of the image. The black stuff is contrast dye, similar to what you may have gotten in a CAT scan. And all these lines, these black lines, are arteries in the liver. And those are the red arrows are where we're going to infuse the drug. And this is that balloon. This is the balloon in the veins. And this is isolation of it. And I'm going to show a video. So on the left video, this is us injecting the contrast, and it's going into the right side of the liver. And that's the hepatic artery. So that's where we're going to deliver chemo. And at the same time we're delivering chemo, we have these balloons in the veins. And again, we inject contrast. These are the veins. And you can see it's completely isolated between the balloons. So the chemo will get delivered through the hepatic artery catheter on the left, perfused through the liver, and then get excreted into this vein, which you see on the right. But these balloons have trapped it. So that chemo doesn't escape into the rest of the body. So that's it in a nutshell. And I'll kind of now jump back to the Chopin trial and show you kind of the data. So the inclusion criteria I talked about, and you could see that, again, they were randomized to PHP or PHP plus immunotherapy. Now, there's always this patient characteristic table in the beginning. And I would say that some of the things to note, most patients did not have any significant prior treatment. So 90% or 82% had no prior treatment for their liver metastases. I'm not talking about what they had in their eye, but in their liver metastases. The other thing is that 90% of the patients had metastases that was in their liver only. Okay, so only 10% of the patients had, for example, lymph node or in their bone or in their lungs and so on. So these are things that we always want to take into account when we're trying to use this data, whether it's from the IR side or from the medical oncology side, to use to our patients, because we want to make sure that it's relevant. I'll give you an example. If someone comes in and they have a lot of lung metastases, but very few liver metastases, then, Dr. Chmielowski asked, and I ask ourselves, does this trial really fit them? And it may not. It may not. Okay, the first thing we always look at is safety. We always want to make sure that any trial, any drug, any therapy is safe. And when we look at this, there was definitely a higher rate of complications and what we term those as adverse events. And we have grading systems in the oncology world, like grades 1 through 5. And kind of our benchmark is grade 3 or worse. So you can see in the two columns, like the second row, grade 3 treatment related adverse event was much higher when you combine the therapies. Now, what gets lost in these numbers is most of these adverse events were very temporary. They were correctable. And so you did have let's say, a drop in your counts, or let's say your blood counts or your white blood cell count, but it was fixed. But we still record that. So that's important to know that, most of these were not necessarily permanent or really didn't affect you in a real or physical way. Okay. Second thing we always look at is, how did the tumors do? In other words, did your tumors stay the same? Did they get bigger or worse? Or did they get better? And we often look at these things called waterfall plots. So on these plots, the each vertical bar is a single patient. And you can see kind of like the midline that's at 0. And if you went above the bar, those are the ones predominantly on the left side of those charts. That means that your tumors grew. And if you went below the bar, that means your tumors shrunk, obviously. So you can see that for each individual, and then the top one is patients who got both therapies, immunotherapy plus PHP. The bottom is the ones who got PHP only. And you can see that a couple things. Number one, most patients actually had their tumors shrink. There is a handful that had their tumors grew, which you can see on the left side, which is unfortunate. But the good thing is most of them shrank. When you combine it, that's the top one. Only 2 patients had their tumors grow, and everyone else did pretty well. Like there, you can see in the blue and the green, and on the right side of the graph, there were some people who went to minus 100. What does minus 100 means? That means on the follow-up scans, their tumors disappeared. So we use a kind of a benchmark called objective response or response rate, and that's on the bottom in the red box. So with Hepzato alone or PHP alone, the response rate was 40%, which is what has been seen in other trials. And when you combine it with the immunotherapy, now we're getting 76%, and which is way higher than, to my knowledge at least, any clinical trial reported for uveal melanoma. We do this other analysis, and I'll kind of try to wrap it up in the interest of time, called Kaplan-Meier survival curves. And so you can see the blue. So on the bottom, the x-axis that's time, and then the y is like overall survival. So you want it like try to be as flat as possible in theory. So the blue is the combination arm, and they did better. So you can see that those curves are separated out. So I think this is, they did show us what's called a survival benefit, both at 1 year and specifically at 2 years. So some of the take-away points of this is what I think we're going to discuss. It seems like it's well tolerated, although it does have a higher adverse event rate when we combine the immunotherapy and the PHP. The tumor response, in other words, do your tumor shrink, is much higher than any therapy, whether it's liver-directed therapy or systemic therapy that's been seen in the past, which is, I think, promising. And that we saw an increase in survival as well. We're going to have a lot of discussion on this, but really the questions that remain in my practice: can I use this algorithm with any immunotherapy? This was Nivo plus Ipi. There are other immunotherapies that you may be on or you may have heard of. Some of them have recently come out. Can you use these results and just kind of apply it for that? There's another one called tebentafusp, also known as Kimtrack, that was not used in this study because it was not available in the Netherlands at the time of the study start. So can you use these results and kind of just extrapolate them to people on Kimtrack? We don't really know these things. And also the number of rounds of PHP and the systemic therapy were limited in the trial. They only did a few, and that was a little bit for practical reasons and financial reasons. So in patients who get 4 or 5 or even 6 rounds of PHP, or a lot of people who get nivolumab and ipilimumab, you may get both, and then you get on what's called a Nivo maintenance. So you get it like the infusion like every few weeks for a much longer time. They didn't get that in this. So if we did that, would we get even better results? And that's it. Thanks so much.
Thank you so much, Dr. Padia. Dr. Padia actually has come back multiple times, both as a guest on the podcast and for previous webinars. And last February, he was a part of the Puzzling Out Liver-Directed Therapies, and he spoke about Hubzado as well as other interventional radiology things. And then we've got a few videos on our YouTube channel. If you're not aware that we have a YouTube channel, go subscribe. And you can listen and see, and he goes into really, really, really strong detail on how Hubzado works. And as an interventional radiologist performing the procedure, and I mean, Dr. Padia, how long have you been doing this specifically at UCLA?
Yeah, so good question. The procedure got FDA approved in late 2023. It became commercially available in the United States April 1st, 2024. We did our first patient April 10th, like 10 days later after commercial approval. We've now done 65 procedures in about 25, 28 patients. We are currently averaging maybe 4 to 6 per month right now.
And I'm trying to remember, I feel like you and Dr. Mylofsky, you both were kind of the one of the first commercially available sites, if not the first commercially available sites. And so, like he's definitely a person to go listen to on the YouTube channel about how the procedure works. So that said, you're right. It's a party. I mean, I've had Hubzado. So those of you guys in the audience, if you have had the Hubzado treatment just on its own, the PHP, please drop it in the chat. Let people know, like, if you've had this procedure. I actually have my 6th procedure coming up next week. So yay me. But I'm super excited for us to get to talk a little more about kind of what this is, why this might be. And a lot of what we're going to be talking about here is going to be based on these doctors, personal experiences and what they're seeing in practice. But also some of this is theory, right? Some of this is we're kind of hypothesizing and guessing as we go and hoping for the best because of the results that we have. But the first question I wanted to lead off with to all of you, I suppose, is the Chopin trial. Is this a trial that patients today can enroll in now? Because I think that this is a big misconception right now. And so Dr. Montazeri, do you want to answer that one?
Yes, so I think there was first a question in the chat about what immunotherapy was used, which Dr. Padia mentioned, but again, it was ipilimumab and nivolumab. We usually use the higher dose of ipilimumab as standard of care and lower dose of nivolumab. In this trial, interestingly, they used the flip dose, which was the lower dose of ipilimumab, 1 mg per kg, and a higher dose of nivolumab or Opdivo, which has lower toxicity rates. And that was one, I think, smart move on the trial design, which is basically helpful to know if we can spare a lot of patients the toxicity, the high rate of toxicity in immunotherapy. To your question, then I forgot your question.
So my question is, the Chopin trial is one that
Yeah,
I'm hearing noised about by patients asking,
right.
"Oh, can I
Oh,
be
God.
part of this trial?"
Yeah, yeah.
And I think that that's a valid question, but
Yes.
it's one that hopefully we can
Yes.
assuage.
So this study was done in Europe and was completed, as Dr. Padia mentioned, about 37, 38 patients on each arm of the study. It was not a huge study, but it was very helpful answering a lot of questions. You don't necessarily need to get enrolled on the trial if you present to one of the centers that have expertise in doing PHP. Again, it's a multidisciplinary, basically treatment, and we usually try to work as a team, and we work very closely with our colleagues in interventional radiology. You can get the treatment outside of the clinical trial in basically a standard of care because both of these treatments have been approved, and the trial showed that it's overall safe for the patients and it adds benefit. the study is not open to accrual, this certain study. There are similar studies. For example, there is a Swedish group that are looking to seeing if maintenance therapy with nivolumab would add benefit, or there are studies looking to um, um, seeing if additional PHP treatment would add benefit.
Yeah. So I guess the big takeaway for you guys listening is you can ask your doctor about this here in the States or, wherever PHP treatment is available. Because I know we have it commercially available in Europe and also in the United States. But you can ask to follow this protocol, maybe would be a better way for us to like kind of talk about it in the future, for today, without feeling like, oh, like I'm going to be limited because it's a trial and I can't do the trial. So that's an important distinction to know. Um, are you guys good if we get into some of the kind of maybe the theoretical why as to why this all looks as good as it does?
Yes.
Because like this is my favorite part. I'm not even joking, you guys. This study came out and I mean as a personal patient who's also receiving PHP treatment and who had already kind of pulled my doctor into, hey, let's follow the Chopin protocol, even though we don't have the results officially yet. I was thrilled to see these results. And I think one of the biggest reasons is that it can feel so much for those of us who don't qualify for KIMTRAC or who don't qualify for trials that have like PRAME positivity or HLA status, like kind of as a stipulation for if you can join the trial. It can feel a lot like we as the patients are a little bit of a sitting duck. So let's kind of dive into maybe the why. And I know we can't spend a ton of time on this because this is theory, but why do you guys each think that combining the Hepzato treatment with an immunotherapy can produce a stronger response than either of them separately?
Yeah.
Dr. Mylovsky, do you want to go ahead and take that?
Yeah, let me take it. So, of course, one of the big questions which we still ask, what would be the outcome if the patients receive the Hepzato first and then immunotherapy followed, or immunotherapy first and Hepzato followed? This is much easier, possibly associated with fewer side effects, or should we combine it? So, assumption why the combination might be better is we know that immunotherapy uses the immune system to fight cancer, and this immunotherapy with nivolumab, ipilimumab has been extremely successful in treatment of cutaneous melanoma. But uveal melanoma is a very different disease. We know, although they carry the same name of melanoma, when you look at the biology, these diseases are very, very different. We apply the knowledge from cutaneous melanoma to uveal melanoma very often, but we saw that the response rate to nivolumab ipilimumab is much lower in uveal melanoma than in cutaneous melanoma. So for immunotherapy to work, you have to have a perfectly working immune system that can destroy your cancer. But the cells that are destroying the cancer have to have a target and have to be present in the tumor environment for them to work. So very often we see when if we can maybe injure the tumor and release the particles from the tumor, this would be a better chance for the immune system to recognize something that should be destroyed. So this is a simplistic way by using PHP, we hope when we cause injury to the tumor, and this indirectly will stimulate the immune system. We are pre-priming this immune system with immunotherapy before we do PHP, so the immune system is already prepared to do its job and to destroy cancer. Of course, there could be a lot of criticism. It's a little bit of theoretical approach to what our explanation, what we see, but definitely this trial confirmed that a combination immunotherapy is probably a combination immunotherapy and liver targeted therapy is a way to go. Advantage also of this approach is when immunotherapy provides the treatment to the whole body. So if you have the disease outside of the liver, or possibly you can develop in the future, immunotherapy can not treat not only your liver, but treats your whole body, which gives an additional point to improve the hopefully outcome.
I feel like that was such a good explanation. Thank you. Dr. Montazeri, as a fellow like medical oncologist, do you have anything that you want to add? And then Dr. Padia, I would love to ask what you, because sorry, I'm very excited about this. So we have one question before we continue talking about this that I feel like we can kind of address now, just so that people have this as a background. One of the questions from an attendee is, are doctors starting to use this combination instead of only PHP right now as a result of the Chopin trial? Dr. Montazari and Dr. Padia, Dr. Chmielowski, like as far as I am aware, you guys have been following something similar to this kind of unintentionally. But obviously now, we have the study results to work with. So, yeah. So, I mean, I guess if you want to go ahead and speak to that.
Yeah, Dr. Kamilovsky explained beautifully. We know that something happens with PHP in the liver that's immune activating and helps immunotherapy work better. Now, the question is, what is the best sequence of the treatment? Should we first start with PHP or start with systemic immunotherapy to prime the body? The answer is we don't know. And we're looking into this. We are at our center also doing a study that includes biopsy of the liver lesion before and after PHP treatment to see what happens in the molecular level and the tumor microenvironment and liver microenvironment. And that may help answer the question as to why PHP can be immune activating. In the real world experience, we know that we need at some point at least both systemic therapy and liver-directed therapy for multiple reasons, because systemic therapy, unfortunately, doesn't work as well inside the liver because of a lot of barriers, because of mechanical barrier, because of basically the external pressure from the tumors to the vasculature and decrease basically vascular perfusion to the tumor environment. And so there is mechanical barrier in delivering the drug effectively if you're doing only systemic therapy to the liver lesions. And also there is barriers inside the liver because of how immune suppressive the liver environment has been designed naturally because of the role of the liver for the body to detoxify everything. So we know that the combination usually works better, even if liver-directed therapies, which our interventional radiology colleagues do beautifully, benefit the patients to control their intrahepatic or their liver lesions. Unfortunately, at some point, there will be disease progression outside the liver. So that's why, in experience, we tend to combine both of these. And sometimes without large data, just based on our own experience, we get to combine different types of systemic therapy with liver-directed therapies.
Yeah, absolutely. And I think it's so important for us as patients to recognize that there are doctors who have been aware of this kind of. I mean, I guess it sounds from what you guys are saying, it sounds like maybe there's some level of synergistic effect, like that they're working, together kind of in tandem, because of, the properties of the immune system that you both explained. And that ability for them to work together gets kind of heightened by combining them in some fashion. And the Chopin study is one example of how that combination has looked. So
Let me just add one,
yeah, go ahead.
few words, So we've been combining immunotherapy with Hepzato since day one of our, since our first procedure. From the beginning, I did not see necessarily a compelling reason not to combine them. So why to wait for progression if we can get benefit of possibly both therapies? And I was really waiting for the results of the Chopin trial, because actually the trial confirmed not only that we can do it, but probably you are improving the outcome by doing it together. We've been doing kind of an assumption, when I want to get the benefit of to give a benefit of both therapies to our patients, but the trial confirmed this is the right way to go.
And I
Yeah.
think just to add to that, nothing really from a scientific perspective in terms of which one goes first and how do you combine many times it comes down to just patient and institutional logistics. These are pretty challenging procedures to set up. Let's say for us at UCLA, you have to undergo some kind of workup, a cardiac workup, and so on. maybe insurance authorization for both the immunotherapy and the PHP. So sometimes, which one comes first ends up being not necessarily a scientific decision or a medical decision, but more just a real life, this is how it's going to happen because this is just how the chips fell.
So we've got obviously lots of questions coming in, and I feel like there's a few of them that I want to address a little bit later. So I'm going to kind of gloss over those for a minute. But let's talk, like you guys have talked and mentioned, the timing and trying to figure out like how do we use this in real time. What are some of the potential advantages and disadvantages that you guys are seeing in practice of using Hepzato earlier in a patient's metastatic journey versus, say, when they're more progressed? Because I think that there's definitely, especially after the Focus trial, there's definitely been this kind of noise in the community that, oh, like Hepzato is for later down the road. So have you guys noticed anything, potential advantages, disadvantages, or what do you maybe potentially hope to see? I'm not sure who actually would be the best one for this, so raise your hand if you're up.
So I could talk about it in the context of other liver-directed therapies. We still do, let's say, for example, quite a bit of ablation or Y90 radioembolization. We kind of worked out our own algorithm at UCLA, and it's not necessarily treating patients with PHP early or late in their course, but we look at the factors we predominantly look at are tumor size, tumor number, tumor location, and how many. And that allows us to stratify and triage people. I'll give you two kind of more extreme examples. Someone who presents with 25, 30 very small, tumors that are size of my thumb scattered throughout the liver. They're going to need a whole liver kind of therapy, whatever that is. You take that in contrast to another person who presents with a single, tumor that's 2 inches, like 5 centimeters, like this big, in the corner of the liver, and then the rest of the liver does not have anything. Those two people are going to get, in my view, are going to get different things. The guy who needs a whole liver treatment, the PHP procedure is really well suited for someone who needs a whole liver treatment. The person who has a single tumor is going to get something much more focal, and that, in our experience, tends to be typically a Y90 radioembolization. And if that person develops multiple tumors down the road, they may not, but if they do, let's say it happens in 6 months or 12 months or 2 years, then we can also offer the Hepzato procedure at that time. The nice thing, fortunately, what we found is that whether you do the PHP after the Y90 or the Y90 after PHP, or you put in an ablation in between those, there doesn't seem to be any adverse interaction. Like, it doesn't pile up. I've had patients who have gotten 3, 4 Y90s and then they went to a PHP. I've had people who went from a PHP and then they got 2 Y90s, and I haven't seen any additive side effects or toxicity. So the nice thing is we are able to like kind of mix and match it. Mm-hmm. This tends to be a little less scientific when we do this. It goes into the weeds and it becomes this is where kind of I would say the art of medicine it plays a big role.
Yeah, absolutely. Dr. Montazeri, what are you seeing, I guess, in practice, of utilizing immunotherapy in combination with PHP at Boston Mass Gen?
Yeah, absolutely. I think, as Dr. Padia mentioned, it at the end comes to tailoring the treatments to each patient. One thing to keep in mind is that most of the time, unfortunately, we don't get to cure the disease, and we end up controlling the disease. So one thing that I keep in mind is that we have to line up as many potential effective treatment options as possible for the patients. So if there is a promising upfront clinical trial that may not be available after this type of treatment, that's something to consider. As also it was pointed out, if the patient has had prior liver-directed therapies or other systemic therapies, we always have the option of using Chopin plus different types of systemic therapy in the future. So it's better that we start from a clinical trial that may benefit the patients in terms of controlling the disease or shrinking it or helping patients live longer and also add quality of life to them up front. But again, at the end, it also depends on, each person's situation, each person's disease burden, and the urgency of, shrinking the lesions.
Let me add a few words only. So, even among my colleagues, sometimes I see, where we ask the question, and very often patients ask, "Oh, if you're gonna use everything up front, what's else left afterwards?" So this is a common question. So if you used, your PHP and your immunotherapy up front, and then it didn't work or stopped working, and this, what are you gonna do next? But I always argue, but if your patient is going to live longer by doing this, means then it will need a longer time for you to use something else. So why do you worry so much about what's gonna happen next if it will take you a longer time, or maybe they don't need the next. Maybe this is too optimistic by saying that, but
No, I mean, as a patient myself, I feel this. And I know, like Dr. Padia, I think in the Chopin study, you kind of referenced, and I think all of you have referenced some of those future studies, like the ones that are currently being done, in other areas, where they're looking at, okay, like, can we figure out, is it better to do the immunotherapy first versus the PHP? But there are also studies of, can we do the 6 rounds of PHP, right? 6 rounds of Hepzato, take a break for whatever duration of time, and then introduce it again later. Like, is that safe? Is it feasible? Is it healthy for the patient? Does it help? I think those are questions that having an FDA approved treatment and having FDA approved, like, clinically available treatments allows that kind of, like what Padia or Dr. Padia said, of like thinking outside the box and the art of medicine. It allows you guys to like really create these custom plans for each of the patients that you see. And I think that that's a huge benefit for just having those FDA approved treatments on the table for sure. But like Dr. Montazeri does bring up a good point that, I mean, there are still trials. The trials can be helpful. They could be helpful down the road. They could be helpful in the moment. And it's really, really hard to know what specifically is going to be the most help to each patient. I know just from a patient perspective, making that decision for me has come down to, what do I want out of my current life, right? What do I want today to look like? What do I want tomorrow to look like? And I have chosen, a route that I feel like affords me what I want in that path forward. And but that's going to look different for everybody.
Mhm.
Everybody has different perspectives on what they want. Um, do
I'm
you
gonna
guys?
support
Oh, go
what
ahead.
Dr. Montazari said, just in is we do have clinical trials. So it's a natural question from the patient. Say, oh, if you have this treatment and showed it worked, why would you offer me a clinical trial, which is an experimental therapy? And I always say, because I want to say, I want to give you as many treatment options as possible. So if this clinical trial we can do now, and then what's available later, this gives you more options in case one doesn't work. So this is just an argument.
Yes,
So
absolutely. Sorry, I just wanted
no,
to
go ahead.
point out that as both of you mentioned, it's definitely a shared decision making. We want to make sure that when the patient, comes to clinic, both, with help of our interventional radiology colleagues, we usually have a multidisciplinary meeting and try to make sure that, everybody has a good understanding of their options and what may be in the future. So we make together the best decision for each person.
Yeah, that makes sense. So while we're kind of on this like leg of clinical trials and like, okay, how could the Chopin trial and the results from this and kind of applying this in clinical practice, how could this affect the future clinical trial eligibility? So what I'm hearing from you guys right now is that, as of right now, there are definitely trials that have exclusion criteria that would make doing, following the Chopin protocol more challenging for entering a clinical trial later down the road. Is that correct?
It
Um,
is, it is correct. It is correct. Right now, some of the trials exclude these procedures. And it is, of course, when you write a clinical trial, it is always a complicated process. You have to have more strict inclusion exclusion criteria, so you can get reliable results of a clinical trial. Also, as although the number of centers that can offer PHP is growing, it still is somewhat a limited number. It's not available in every country. So if you mandate PHP before that, the clinical trial might not be available to many, many people in the world.
Yeah, that's a good point. So I guess my question, maybe just naively as a patient, is as we have something that has the potential of taking two standard of care therapies and being used in tandem, right? The Chopin protocol, so to speak. Is there room for the future of clinical trials where somebody could follow this protocol as standard of care therapy and then enter a trial later if that standard of care therapy fails down the road?
Yeah, absolutely. I don't know. Dr. Kremlowski, do you want to answer or should I start?
No,
You
go
can
ahead.
go
Yeah,
ahead.
I think, and that in reality, because this is a field that has had less treatment options in it, that's why we have clinical trials mainly in the frontline setting. That will change in the future once we have more FDA approved options available. And it will hopefully be more inclusive for the patients. There are trials coming up in the near future that are going to be available after PHP, after immunotherapy. And I hope that in the future, the way the studies are designed, they allow patients to have had multiple options in the past.
I think we got to remember that this Chopin data got presented in November of 2025. It hasn't even been published yet. It's in press right now. So it always takes, as Bartos mentioned, it takes forever to actually, from the time, like, if the three of us were to design a trial today, by the time we enroll the first patient, it's like 18 months, right? I mean, it takes a very long time. It's very painful it's very painstaking to do these trials. So I do hope that all the new trials will allow this because I do think it's, when we're starting to see response rates of 75%, to tell patients you can't get this if you want to be on a trial. While I understood that 2 years ago when we didn't have this level of data, this level of numbers, I personally feel like it's a little bit unfair. So unless the trial has medications or drugs that could make someone really sick because they got the PHP, in other words, they're really worried about an interaction with prior PHP. I feel like the new era, 2026 and going forward, they're going to have to. I think the sponsors of these trials and the people who design them are going to really have to try to accommodate this procedure at least in their armamentarium.
Yeah, I mean, I would love to see that. Just as a patient myself, because I mean, everybody's story as a patient is so different. Everybody listening, we each have such unique journeys with metastatic disease. Some people haven't even started the journey with metastatic disease, and correct me if I'm wrong, but is there any noise in the Hepzato space of using Hepzato kind of more adjuvantly, saying, okay, you've got a class 2 patient, we're going to treat you with one or two Hepzatos, because like this has been my catch 22 on Hepzato all the time, and I talk about this till like I guess I'll talk about it till I'm blue in the face. It's there to treat what we can't see, right? So if we can't see the metastatic disease before it metastasizes, to me it makes total sense that this could be an option adjuvantly. But I understand like that's complicated.
Yes. Well, it's actually the most important thing is that you said it's complicated. And I think part of it is that this is a big procedure. It was when we started this at UCLA in 2024, it was a massive undertaking um, to get this off the ground, and it is very involved. It is not like it is not easy to do. It is not easy to set up. It takes, you saw some of the pictures in my presentation. There's 15 people in the room,
It's a
so
party.
we have to show, if we were to do something like that, we would definitely have to show significant value and benefit. And if we show just like a small benefit like this, I'll be honest, I'm not interested in this. We're
Yeah.
interested in home runs.
Mhm.
We're interested in big leaps because this is, in my personal opinion, I'm the guy who does 99% of them here. It's very tough to do these procedures. That's why, as Cam said, it's not available at every center. It does take an infrastructure. It takes a huge team to do this. So we have to make sure that we are going to have a significant chance of benefiting people if we offer this therapy.
Mm.
But I do agree, when an attempt to use it maybe in the adjuvant setting would be of interest, Of course, one of the problems which we face, we don't even fully know how to identify patients who are at high risk. Traditionally, and we are guilty of it too, we kind of repeat old data saying that half of the patients will develop metastasis. This every paper starts with that, which is probably not true because modern data say yes, the high risk patients, half of them will develop metastasis, but not everybody is such a high risk. And this, yeah, I keep saying that maybe there is something in Southern California when in my hands only 20 to 25% of patients develop metastasis, not half. But so I just say so. Each center defines, not saying each country, so who is the high risk, how to really predispose. So you are not exposing people who are possibly already cured with a local therapy on their eye to the therapy which is associated with cost, but side effects and everything. But if we can define better, with these people, high risk people, then I think adjuvant treatment would be interesting to see if we can delay or prevent development of liver metastasis.
Mm. Do either of you, Dr. Montazari, Dr. Padia, have anything else to add?
Not really. That's well said.
I wanted to say one more thing, is so sorry I'm talking so much,
No,
but
you're
one
good.
thing is I wanted to just show some optimism because when many patients who come and they are really diagnosed with uveal melanoma upfront, or they are already, later on they may be diagnosed with metastatic disease, they open the internet and say, "Oh, my median survival is 12 months. It means I'm gonna be dead in 12 months." Mm, And when this immunotherapy doesn't work, it says it doesn't work, and this procedure is associated with so many side effects. Uh, as we try to point out, every journey is different, every patient is a different story, but we do have patients who do well. And we do have patients who are alive 3 and 5 and 7 years later. And and so this 12 months which you saw somewhere is probably not true. There will be people who have very aggressive disease, and no matter how aggressive you want to be, we will not be able to help them. But there are patients with our therapies and the combinations and sequencing and development of new trials and new therapies, really we are making a difference, and the patients with your disease can live longer.
Yeah, I love that.
Absolutely. Um, I love these words of wisdom from Dr. Kimilowski. Yes, that's what we share with our patients, that these are mainly historical data when there was no effective therapies. Times are changing, there are newer, more effective treatments coming along, and we all have like these encouraging stories from our long-term survivors, which are, giving all us hope and also helping us figure out what helps some patients live longer. And that may help us, design better studies in the future. There was one question in the chat that I wanted to answer. They were asking, what about the patient's HLA-A*02:01 positive? And what about, like, I think their question was like, can they have also PHP? So again, we know that most patients need a combination of systemic plus liver-directed therapy. As you know, tebentafusp was approved as a drug that can help increase survival and give survival benefit. So that can be used as systemic therapy depending on the burden of the disease. Again, it's a multidisciplinary discussion with our colleagues. And sometimes we add liver-directed therapies, different types, PHP, Y90, immunoembolization times, or radiation, cryoablation, different types, depending on the size and location of the lesion. And we also, with the help of our colleagues from different centers, showed that there was benefit in addition of liver-directed therapy to tebentafusp. So those are things that we need to basically think out of the box and be creative and help make the best treatment option for the patients.
We've been
As well.
doing that too, Cam. Bartos and I have had several patients on tebentafusp and PHP. From what I can remember, like everyone's doing super well. Like dramatic. Again, these are anecdotes, so I don't want to, generalize it to 100 people, but like I've seen dramatic results, like crazy results. I would love to see a trial on this. Even if it's a single arm, combo trial of tebentafusp plus PHP. I would love to see something like that. Make it simple, clean, straightforward. You don't even have to randomize patients. Just enroll, 75 people. I think that could be done so we can at least, in a systematic way,
Mm.
show what the response rates and the survival is.
Definitely, yeah. You point out a good basically point that we definitely need to do it in the right way. And the reason for clinical trials is that we have to show scientifically what exactly works instead of, a few anecdotes from each
Yep,
of us.
absolutely.
So I do want to kind of tap into a little bit of just kind of how we can use the Chopin protocol in practice. I know that all three of you have seen it used and have utilized this kind of protocol in practice. But what room is there for personalization? Because, like, I know Dr. Mylofsky, you mentioned that there's a lot of concern from patients around, oh, like, I don't want to use that ipi-nivo that has really really bad side effects. Like, there's a lot of scare around the use of what looks like historically has been a pretty ineffective immunotherapy, right? At least for uveal melanoma just on its own. So um, do you see patients coming to you that have those kinds of concerns, and how do you address those, like, kind of in practice? I guess this is maybe more of a medical oncology specific question.
We always respect concerns. We try to reassure not everybody has terrible side effects, and if the people have side effects, we know how to manage them, and we can help them to manage the side effects and be with them. They do have quite an dangerous disease. So if I always say, let's be as aggressive as we can because the payoff might be the best, but of course, we respect concerns and we try to explain and take through
Yeah, absolutely. So if a patient comes to you and says, okay, like, I see the Chopin results, they say that we're using a lower dose ipilimumab and kind of the normal volume of nivolumab. So I guess my understanding this is the Chopin results used kind of a modified version of the dose of ipi-nivo to start. If I, as the patient, want to say try something different, I wanted to try, maybe I've heard about Opdualag, or I've heard about just something else that is an immunotherapy that might have some level of potential. Like, what level of discussion do you guys have with patients, or have you ever had a patient who comes to you and says, yeah, I don't want to do ipi-nivo, or I can't? Maybe they've tried it before and they've had really poor side effects from it already. um, how do you guys address that?
Cam, do you want this?
I was hoping you would go first.
Yeah.
I'm joking. Yeah, and that's a great question, Danny. And I think Bart and I probably both have had these situations that probably because of concern for toxicity or prior toxicities and maybe a re-challenge, there is worry that, Epinivo may not be the safe choice for the patients. So in reality, we have some data that, as you know, the responses to single agent immunotherapy are much lower. Um, so there is that challenge that you're exposing someone to a drug that has a low chance of working and higher chance of toxicity. But there's also this other combination of nivolumab and relatlimab that hasn't been tested in combination with PHP. In general, we tend to do something that there is some data on it instead of just mixing like cooking in the kitchen. But sometimes we end up doing that because we see that there is some need for systemic therapy for the disease that's growing outside the liver. And
Mm-hmm.
if Ipi-Nivo is not the safe option, maybe we can go for another option called Nivorel. Or sometimes Ipi-Nivo was tested before and there was disease progression. So we use this other combination to see if there are some chances. Again, there's not a lot of data, but there were some cases that had some responses with the second combination after ipi-nivo. We know in cutaneous melanoma, the chances are lower that after there is failure to one immunotherapy combination to use the second one. But again, that's something that needs to be discussed, particularly for each patient. And sometimes there are success stories. So at the end, as up to the patient and the oncologist as a team to make that decision in a situation that there is a rare disease with few treatment options.
To
Go
add
ahead.
just one sentence, one thing which we know, which we know, I do not generally recommend Obdualac as a first line sheet. So if it is, but we have some already data in uveal melanoma, they come in from Florida, is that it does not appear as Obdualac alone as a first line treatment is much better than a single agent nivolumab. But if somebody already had nivolumab, ipilimumab, if they had these other treatments, I'm not saying, oh, you shouldn't use Opdualag at all. But if you try to use a first-line treatment, probably it's not the best choice.
I'm the patient who told my doctor we're doing this instead.
Mm. No, it's okay.
I said I don't like I had too many personal issues with the possible side effects that could affect my day-to-day life as a 34-year-old woman with Ipi-Nivo, and I said I would, if we're going to try an immunotherapy, I want to push for one that has a lower side effect profile. It ended up, at least in my case, probably being the right choice because I developed a grade 4 side effect from Opdualag that I probably would have even more likely developed with Ipi-Nivo. So anyway, there's so much room for personalization here, and I think that what I hope that we as patients can take away from this is that because we have the Chopin data to fall back on, that's why we can kind of personalize this, why we can piece out, okay, maybe we try this instead, why we can fit the pieces of the puzzle together with the border of the puzzle's already been made, if that makes sense.
One more sentence, since you mentioned side effects, that you develop side effects on immunotherapy or anyway doing your combination treatment. This is a natural concern for the patient. Say, oh my God, I was supposed to do this cycle, then PHP, then another and another, and suddenly I have a side effects and they have to put my immunotherapy on hold and this. So I'm right now not following the protocol. So I'm completely, it's a disaster. Um, we have to say, when what we want from our drugs, from our immunotherapy, is not necessarily how many doses you receive, but how active your immune system is. Because it's not the drug that's doing the job, it's the immune system that's doing the job. So if you develop side effects, it means when your immune system is in hyper mode, and that's why it's giving you side effects, you may not need the next dose. And so I would say, don't get discouraged if you develop side effects and your treatments are delayed or something. This doesn't not necessarily mean when it's not gonna work.
Yeah. That is actually one of the questions we had kind of to expand on that is, where did it go? Side effects. How often, or I guess specifically with this combination approach, Dr. Padia, where can patients, best read the information around the study, or is it not published available yet? Because we
So
have questions about like how the side effects looked for the group of patients in the study.
yeah, so great question. I have the same question, in fact, because the study was presented at a medical conference in November 2025. It is currently what's called in press, meaning it is about to be published in, I think, what's called the Lancet Oncology. And last I heard, it will be published in the first week of March.
Okay.
You can hopefully download it. Again, it's going to be medical jargon. That's how all scientific publications are, but it should be out in March. And I'm actually, I don't know. I was not an investigator on the trial. I'm looking forward to the details as well. You can always, I'm sure you can Google it. If you Google like uveal melanoma and Chopin, you can get summary stuff, like summary slides, and even most of the slides I did are open access slides. You can get the kind of the basics of the trial and the trial results that way as well. And also, you can, honestly, feel free to just email the primary investigator, who is the lead investigator. And I've met them. They're super nice. Mark Bergmans is the IR. and Eileen Kapitajian is the medical oncologist. They're wonderful people. You could probably just email them and say, "Hey, can I get a summary?" and they'll send it to you.
No, I love that. That's so cool. I didn't know you could do that.
Yeah, I was
Oh,
just gonna point out the trial has become so popular that when you Google, first it says Chopin melanoma, then it's Frederick Chopin, the
mm.
musician.
There you go. Then first,
But
first
ask
this,
your
then the
medical
musical.
ask your medical oncologist also,
Yes,
they
absolutely.
also know they are aware of data this, so they can look up and they might not have been a part of a
Mhm.
clinical trial, but they can guide you.
And this answers one of our other questions from one of the attendees. They were asking, is the Chopin protocol widely known by treating oncologists yet, given that the trial results are not published? So what I'm hearing is you guys are seeing it noised about far more in the last couple of months. Is that feeling pretty accurate? Do you think it's getting more noise?
It is correct, but I have to say we are a little bit biased because we are in a small group of medical oncologists who are melanoma oncologists who have also interest in uveal melanoma, not only skin melanoma. So this group, so if you have a general oncologist in smaller practice or this, they may not be fully aware,
Mm.
So but the patient can make them aware, and then they will start digging into it,
Yes,
But
absolutely.
There are centers of excellence in each part of the United States, at least, that there is this multidisciplinary group designed for delivering PHP to the patients, including interventional radiologists who lead the treatment, their perfusionists, techs, cardiac anesthesiologists, surgeons who admit the patient, high-level care units to take care of the patient overnight, and then us medical oncologists that work together. So one thing is to, know which centers are available close to you, just like Dr. Padi, we have been uh, doing this, and Dr. Kimovsky doing this on the Upper East Side of the states and Massachusetts. And so, yes, maybe other oncologists that are not focusing on uveal melanoma are not fully aware of this, but it's patients like yourself who are devoting their life and career to make others aware. That's very helpful so that the patients can actively seek for novel treatments.
Oh
I was
no.
going to also just add, if you're not aware, in the back end of our Zoom event here, and also I'll just say it out loud, Hebzato Access and the hebzatokit.com. Those are some really unique resources where you can go as a patient or as a caregiver, and even other practitioners. We can search and we can find their currently open sites. They're really good at updating the most recently updated or most recently opened sites. So, for example, I think the most recent site that just opened is actually in Texas, in Dallas, Texas, I think, at MD Anderson there. And so those updates to which sites are open, those are actively being, put up online on Hepzato Access, hepzatoaccess.com and hepzatokit.com, both of which are resources you as patients can go into the back end of this event, even after we conclude the event, and you can access those links. They've got a map, like you can just search it. Okay, I got an update that OHSU in Portland is the most recent site. So like these sites are opening rapidly. I mean, they have really picked up some good momentum. I know we've got Dallas, we've got Portland, we've also got I just had heard about Utah. Like Utah has a site, and they are also utilizing the Chopin protocol. And so, I mean, there are definitely doctors out there who are aware of this. It's just a matter of maybe finding them. And I think sometimes as patients, we have to be willing to step outside the box of, oh, I'm most comfortable with this doctor, or I've been told that this is the only doctor I should see. But what about maybe going outside the box and getting a second opinion? Like there's definitely room for that for sure. So Dr. Padia, you mentioned you average about 4 to 6 procedures per month. Is that meeting the total demand of like patients you have who want Hepzato, or do you have like kind of a backlog and you have to turn patients away?
No, we don't necessarily have a backlog. We would have a backlog, but what we're doing, as was mentioned, is that more and more sites are coming on board. So our referral base a year and a half ago was basically the entire Pacific time zone and Mountain time zone. Like basically everyone in the western half of the United States was flying into UCLA to get this done. We've been the company, and we've been part of it to train other sites. For example, Salt Lake City in Utah is now doing it, and UC San Diego is doing it, and Cedar Sinai in City of Hope in Los Angeles is doing it. So that's helped. Because I think if that didn't happen and then the Chopin stuff comes out, then I don't want to be backlogged because I don't want to delay patients getting care. I would rather have them go locally if they can get it done in a good way and get it done by caring physicians who are technically skilled. So we're probably we're like just for us, we're like full for February and March. I think we have openings, but so we're pretty much like riding the wave right now. I think if we have more patients, we may start to get backlogged, and so and one of the challenges from a logistic point of view is that we reserve a lot of room time for this in the hospital. There's a 4 hour block. We have to get certain anesthesiologists for it. We have 18 interventional radiologists at UCLA. There's two of us who do this, and I do most of them. So, all the kind of stars have to align for us to find a spot, and that's why we do a certain number per month.
Gotcha. Okay, I think that makes sense. Let's see. How frequently would you guys expect a patient to need the treatment? So I'm gonna assume this question is asking how frequently would you expect a patient to need the treatment, kind of outlined in the Chopin protocol, for a long-term intervention. And I think maybe the general first answer to that question is we don't know. We don't know yet because the Chopin trial only covered 2 PHPs and was it 3 ipilimumab and nivolumab?
Four.
It was 4, as Dr. Montazeri says. So do you guys have a theory? Have you seen anything in your own clinical practice of utilizing this protocol?
One thing which we don't even know in the original development of PHP was that people were getting 6 procedures. We don't know, we do 2, and then here at UCLA, we usually take a break a little bit, and say, okay, let's see what happens, because we had patients that didn't need the third procedure for a year or something after the original. So do we need to stack them up front? So the approach which we use, we kind of adjust to what we see on the scan. If we see that there might be active disease or worsening disease, then we do again but we don't necessarily do 6 upfront. Is it the better approach or worse? We don't know that. These are very good questions. But we try to space them out.
There's a
Okay.
lot of debate in the IR community about this. We've had, meetings internal like with me and 15 other interventional radiologists, and we kind of all disagree on this. I think I'm right. They think they're right. So people are like, look, let's just offer 4 to 6 all up front. As Bartos says, we take a more patient approach in terms of like, do we do 2, we restage, and then we make a decision. Um, and part of this is to get a little bit more long-term durability and longevity instead of rushing to do 6. And the key thing I want to remind everybody is that while these procedures are well tolerated, it does cause some fatigue for a few weeks. It does cause some nausea for a few weeks. It can drop your white cell count. So it's not like it's, nothing. And if you get, in my experience, if you get 6 right up front, it can wear you down a little bit. So my personal preference, and again, this is anecdotal, is to space them out a little bit, as Bartos said.
What are you seeing in practice, Dr. Montazeri?
Well, so the way the focus trial was designed, it was like 6 to 8 weeks. And sometimes in some patients, we do more closely depending on the disease burden. Again, yeah, we may make different decisions based on how much disease we see, based on how, physically a patient is doing and how strong they are. It's technically, Dr. Pite is the best person to comment on that than the rest of us here. Or actually, Dana, you're the best person to comment on it. But as they describe it, it's like running a marathon. So it's a lot of burden on your cardiovascular system. Yeah, it's not like a walk in the park, but sometimes when you worry that, there is a lot of disease and you have to continue the treatment, we do back-to-back treatments. As we have been saying it during this whole hour and a half, is that we really don't know whether unless we compare them head to head. So there needs to be clinical trials comparing more PHPs versus fewer PHPs. And that may be also difficult depending on, how similar the patients on each arm are.
Yeah. So to be determined. We're still figuring it out as we go, patient to patient. I think what I hear kind of from patients in the community who have had the PHP treatment, who've, continued having Hepzato to some degree, is that generally I think a lot of doctors are following at least okay, we do two, then we check and we see what's happening, and then we make a decision for the next two, and we kind of just graduate from there, with the kind of end goal in mind of we hit six, and that's when, if we hit six consecutively, then we got to take a solid break of some kind, just to give the body a break, give the immune system and all of it, give it a break. Having had five, upcoming on six, like, I can say I'm excited to get a break. I'm excited to get a break. One of the things that we had a question come in that is kind of back to our trial discussion was, and I think this will actually help maybe just define a little more about the different types of clinical trials. This person says, it seems if I choose a clinical trial, there's still a 50-50 chance that I end up only on the control arm, not the experimental drug. And if you wait too long, your liver is more than 50% affected, then you might become ineligible for PHP. So I guess there's kind of two parts to this question that I think we should address. One is, are all clinical trials like that? Because I know the answer, but I want you guys to give the answer.
So not all clinical trials are randomized. More advanced clinical trials that may lead to the approval of the therapy, when usually they are randomized and they are compared to standard of care. I talk about clinical trials to my patients probably every day, and options, and why clinical trials is an option, and very often there is a standard arm as a control arm. When we design these trials, or we design, or they are designed, and they are reviewed by ethics committees and scientific committees, if there is a randomization, it means when there is a question, when we don't know if a new therapy is actually better than the old therapy. Of course, we are excited about new therapies. That's why we pursue these clinical trials. But if we knew when the new is better than the old, we would never randomize patients. So what it means, if you get randomized to the control arm, it does not mean that you are a loser. Then, oh my God, I had a bad luck. You might be getting actually a better therapy than whatever new is coming. So um, so I would not discourage people say, okay, I'm on a worse arm. There is, of course, the concern if the disease progresses, and this, will I be an candidate for Hepzato later? But what happens is these patients are usually on clinical trials followed quite closely. So anytime we see worsening of the disease, we take the patient off the clinical trial and switch them to whatever we think is appropriate.
Okay. I don't want to spend too much time on this question, so unless somebody's like itching to dive in and weigh in, I want to move to the next one, which I think we actually already answered this one. Dr. Montazeri, did you covered the one about like the different class, like class 1 PRAME positive question at the bottom, right?
No, I didn't see that. Sorry. Would you please?
Okay, so I guess this is really a pretty general question. I think and whoever this was, please, clarify your question if you need to, but based on, some of the things that I had discussed earlier, is PHP, the Chopin protocol, is this something that is available to someone who is PRAME positive class 1, who ends up metastasizing?
Yes. So it was not basically it's not selective or randomized based on the PRAME status or HLA status. And again, what we're doing is not within a clinical trial setting. It's basically extrapolating data from that clinical trial that was a positive and encouraging trial and using it in practice. So depending on what you have been treated with in the past, we may decide to add immunotherapy to the PHP treatment if that's the right approach. But PRAME positivity doesn't change that, or GEP class, gene expression profiling class, wouldn't change that decision.
Okay.
Just one more sentence, since I'm itching, is because very often right now patients come and say, "Oh, I put in this AI engine and this, and the information, and they told me I have to ask you, what am I class 1, class 2, am I PRAME positive, PRAME negative?" And it's an important question, but it's an important question for people who did not develop metastasis, because this predicts the risk of developing metastasis. Once you have metastasis, this information is is not important anymore, because
Mm,
you already, so even if you were class one prime negative, the best prognosis, if you develop metastasis, you were in this unlucky ones who did develop. So.
yeah. No, that's a good point. Okay. How about you guys, Dr. Montazeri? How long have you guys been doing PHP at your center? Like, have you had any patients receive more than 6 treatments? And this is for all of both.
Yeah, so we have been doing pretty much about 2 years. We have now given about 90 PHPs, 36 patients or more, maybe. That was the latest data that I had. We have been giving about 4 cycles, sometimes, but I think the average is 4 cycles that we have been giving to some patients. We have been giving 6 cycles of PHP so far. I don't think we have um, done beyond 6 treatments. It may, in the future change if there is like a big time lapse between the 6 treatment and if we want to try that again.
Yeah.
But I don't know if my colleagues at other centers have had.
Yeah, I mean, I think part of it, Danae, is that, as Cam said, this has been available commercially for 2 years. So I think if you ask that question again to us in a year from now, we may have a different answer. But I have not had any patients more than six. That being said, I'm not really opposed to doing more than six as long as they've tolerated the
Yeah.
six before, and as long as we think that there is benefit more than risk. We always do this. Anything you get, like medications or procedure, we do a risk benefit analysis, and we find, look, I think after six, maybe your risk benefit ratio may change a little bit compared to procedure number one. So we have to discuss that, and we have to weigh that in. So it's not necessarily a straightforward yes, you can do more than six or no, you can't, because it's going to be, as we kind of said the whole hour, it has to be individualized.
Yeah.
I suspect we will end up doing more than six on certain patients in the future. We just haven't yet, but that's also because we started 2 years ago, just like
Yeah.
MGH.
Well, and I mean I'm not going to say exactly where, but I can tell you that I have spoken to patients who are in Europe who are saying that in Europe they are doing more.
Yeah.
So there is definitely hope that that could happen in the future. Just here in the States, we haven't quite gotten there yet because we haven't had it here available long enough, is what I'm hearing. Um, as a patient about to complete six who happens to have tolerated it really well, I'm in the camp of I volunteer as tribute. Like, I will volunteer to do it again, 6 months from now if we think that there's the potential that this could keep me cancer free for even longer. But I happen to be one of the patients who tolerates it insanely well, insanely
Mhm.
well compared to other patients. Maybe that's because I'm younger. Maybe it's, I mean, who knows? But I think that that's one of the big reasons for this discussion, right? Is that this is something we hope we can see some personalization for patients, and as patients, you guys can be your best advocates. And if you're like me and you think that you tolerate it really well, then ask. Like, what's it going to hurt? The worst they can say is, nope, not yet. Here's why.
Yeah, absolutely.
Okay. Well, I think to wrap, I want to just have us, wrap up like maybe one important message that patients who've listened in on this webinar could take away from learning about the Chopin data and the study when they're making treatment decisions with their care team, whether they're newly metastatic or somewhere in the middle, somewhere in the mix.
I just want to repeat what I said, uh, be optimistic. You can see from this data when we are making a difference and patients live longer. So have hope.
Yeah, absolutely. Dr. Montessori?
Yes, hope always helps. Today's the day for hope and love, and I hope that's every day. And I want to thank your audience for, spending their Valentine's Day with us. I hope this conversation has helped them. It's definitely a better, not never. There is never a good time to have this disease, but definitely now is better than 10 years ago or even shorter. So be hopeful and be on the lookout for new treatments.
Absolutely. Dr. Padia?
Yeah, I just want to echo my colleagues, and I'm relatively now optimistic. And I'll be honest, I'm a glass half empty type of guy. So I think that some of the data has been super promising, and we were seeing fantastic results in most patients. So I would say, to encourage you guys to everybody to not give up. And it's nice to see, we're starting to, it used to be like the trials were kind of inching and now we kind of seeing big leaps. So I hope that not just this, but other trials, both in the medical oncology space and in the IR space, continue to build on that. So I think that, we're going to start to, in the next 3 to 4 years, we're going to start to see really kind of interesting and new developments in the uveal melanoma space to get people better and better results.
Yeah, no, I mean, I love everything that all of you guys have talked about today. I really appreciate all of our participants on the webinar questions, people sending in, their feedback and their 2 cents in the chat. All of you guys who, just like Dr. Montazeri said, spent your Valentine's Day here with us. We could not have these kinds of discussions without patients participating. It really does help. So thank you guys for participating and just being your own best advocates and being here to learn. I do want to give just a brief disclaimer that nothing that we shared here should be taken as explicit individual medical advice. I am a patient. I'm not an expert. These doctors are experts in their fields and they are sharing, but none of them are, well, actually, a few of you said that your doctor was on here, but for the most part, this might not be your doctor. So make sure you take this information, what you've learned, take these questions maybe that you have, or take the information to your doctor and just say, look, I like this. Can we talk about it? Get the conversation going, especially if you have an oncologist who maybe hasn't heard of the Chopin data. And let's just open up the conversation. I think that that's really the best thing that we can have as patients is doctors willing to have the conversation, and doctors willing to let us drive our care. So I want to just thank these 3 physicians for being a huge part of that kind of a conversation and just seeking to really individualize care patient to patient. Obviously, research and experience, anecdotally and in a research setting helps to guide those decisions. But thank you guys for just showing that, patient preferences matter and that you guys have, the goal of helping patients live their absolute best life, even when they're dealing with metastatic disease.
Thank you.
Yeah,
Great.
absolutely.
Thanks so much, guys.
All right. Well, as we close out, I want to just say a huge thanks again to our sponsors for the webinar series. We could not have done this without them. So thank you again for being here, you guys. Thanks for our sponsors, and we will see you guys next time. I was gonna tease this earlier, and I forgot to, but I will just tease it now. That our next topic is going to be covering more about ctDNA, which actually has some really good information coming out soon in the HEPZATO space as well around ctDNA. So we're getting really, really excited for that next webinar. Be on the lookout on the newsletter for both the study results as we get those when they get published, like Dr. Padia said. A Cure Insights newsletter, we will put that out in our newsletter as quickly as we can and on our social media. So thanks you guys for being here. Make sure to subscribe. And if you have the wherewithal to send a donation in or send a donation form to your friends and family to help us continue educating patients and having programs that can aid patients in getting care. We would absolutely appreciate that. So thanks again for being here with us, and I will let you guys get back to your Saturday.